A warm welcome to you all to yet another exciting webinar by Blue Connect. Today we bring you the Acting Registrar of the HPCSA, Dr. Kwinda, presenting the topic Offences under the Health Professions Act. But before we cross over to the good doctor, allow me a few opening remarks. To those of you who are joining our webinar and platform for the first time, I have in some of the sessions mentioned at length what this platform is about, but maybe for your sake, I will quickly summarize. So the platform was conceived after observing that as healthcare practitioners, we don't share knowledge, information, and discussions and debate across our man-made professional lines. So what we mean is, as optoms, we speak amongst ourselves. GPs do exactly the same. Speech therapists do exactly the same, and other professionals. And yet this is despite the fact that some of the issues that we are grappling with are common across all the healthcare professionals. For instance, the funding model is a common challenge to all of us. The introduction of ICT or fourth industrial revolution is a common factor that affects all of us. The issue of corporate involvement is also an issue that affects all of us. So I have observed as well that we are one of the few sectors that does that. Having worked with engineers, I've observed that they have a platform that connects all kinds of engineers to share knowledge and solve challenges. The same yet is done by management sciences and so on. So this platform was created to bridge the divide amongst us as healthcare professionals and disciplines alike. It was created to promote and facilitate discussions, debate, and sharing of knowledge across the entire healthcare space for the benefit of all of us who are in this sector. We call it Blue because the idea is to dissociate it from any group, racial, professional, or otherwise. It's just Blue. It's a safe and professional space to debate and share ideas on. So we invite you to keep on attending these sessions and also to suggest topics of interest that you'd like to learn or share with the rest of the healthcare professionals. After all, this is your space. Lastly, we hope to keep this platform free for all healthcare practitioners. But as you know, there are costs involved in putting these sessions together. So instead of charging these sessions, we opted for the option of requesting you to pledge whatever you can to sustain the platform. So throughout the sessions, we will send a link for people who want to pledge to the platform. You click on the link and just follow the link. Also note that the platform doesn't allow us to capture your HPCSA registration numbers. So you will be requested to email your HPCSA registration number to an email address that will be published during the session so that we can be able to allocate the points for you. Without further ado, allow me to introduce the good doctor, Dr. Kwinda. Dr. Kwinda is the Ombudsman of the Healthcare Professional Council of South Africa and is also the acting registrar. He is an ombudsman, a post that he has occupied since March 2014. On 21 February 2020, he was then appointed as the acting registrar of the HPCSA. Before joining the HPCSA, Dr. Kwinda was a medical specialist or family physician from July 2011 to February 2014, working for the Department of Health at Chilidzini Hospital in Venda, the same hospital where he did his internship in 2002. And also heading the National Health Insurance Pilot District in Limpopo. He spent a total of 9 years at Donald Fraser Hospital in Limpopo, starting with his community service there. It was during this year of community service that Dr. Kwinda was initiated into the management cadre when he was appointed as acting senior medical superintendent during his community service. And then he became the senior clinical manager from 2004 to 2011, becoming the youngest clinical medical manager ever in Limpopo. His exceptional achievements earned him the award by the South African Medical Association for commitment to the improvement of public health services in rural areas in 2004, and contributing to the continuing professional development activities in the profession. Award for Best Clinical Manager for Vembe District for the 2007-2008 financial year. Award by the Rural Doctors Association of South Africa, RUDASA, for Rural Doctor of the Year in 2008. Dr. Kwinda is the main presenter at the HPCSA organized continuing professional development activities otherwise known as symposia, with 2 CEUs in ethics earned by practitioners at each activity. After matriculating at Poppy Secondary School, he obtained a Bachelor of Science degree from University of Venda in 1995, followed by an MBCHP at University of Natal in 2002. In 2011, he obtained his MMed Family Medicine from University of Limpopo. And in 2016, he obtained an MSc Med Bioethics and Health Law with the University of the Witwatersrand. Dr. Kwinda is also a certified mediator and is currently studying towards the Bachelor of Law degree 3rd level with the University of South Africa. He has been involved in different leadership roles at both professional level and community level, some of which are South African Medical Association, member and vice chairperson of the Medical and Dental Professions Board, vice chairperson of the Aeromedical Committee, Civil Aviation Authority, current, council member and member of the Audit and Risk Committee of the Governance Committee, Valley University of Technology from 2017 to 2018, member of the UNESCO National Bioethics Committee, current, ordained pastor at the United Apostolic Faith Church, and that is also current. Dr. Kwinda, I think after that lengthy introduction, let me hand over the slot to you. Thank you so much.
Thank you so much, Mr. Kove, and good afternoon, colleagues. Thank you so much for inviting me to come and do this presentation here. And I'm really, I have to say, impressed by this initiative, which is very clear in terms of its objectives. A platform where there is no divide in terms of which profession we belong in, and we can be in a position to discuss the common issues. I've always said I'm waiting for a day when health professionals in our country can unite behind a common cause. And I think this is really taking us to that particular direction. So what I'm going to be doing now, I will talk about offenses under the Health Professions Act, but I'm one person who would like interacting with colleagues and imparting colleagues with knowledge and information. And I'm going to use this opportunity also to share with you before I really go deep into the offenses, which I know if you really go to our website, you will find this information there, because we tried by all means to put together a document called Offenses under the Health Professions Act, for the purpose of ensuring that practitioners at least can know what is it that they can do. And in terms of, Section 49 of our Act, then they can be disciplined if they are found to be on the wrong side of the rules that have been promulgated. Now, let me just do the sharing here of the screen. Okay.
Are you winning that, Dr. Kwinda? There we
go. There we go. Right. Okay. What I will start with, like I know, this I always do whenever I speak to colleagues, is just to give you an overview of what the HPCSA is. And this is based on the fact that whenever you listen to colleagues, you can really see that colleagues don't understand who the HPCSA is. Recently, when we were dealing with issues of the annual fees, the media statements that we have seen, written by professional associations, were a clear indication that there is still a serious problem of ignorance, even amongst us as professionals, especially when you find a situation, and we are not saying that colleagues cannot, using any other platform, have inputs where you find that colleagues still believe that the issue of determining annual fees must be consulted with all the stakeholders and all those kind of things. Now, this brings me to the point that we need to understand that the HPCSA is different from professional associations. It does not represent practitioners. Unlike the professional associations, they represent the interest of their members. That's why we always say, as a practitioner, you are not a member of the HPCSA. And we have seen colleagues sometimes will even write in their bios or in their CVs that I am a member of the HPCSA. You can be a member of council, you can be a member of the board, you can be a member of one of the committees of council or the committee of the board, but as a practitioner, you are not a member of the HPCSA. Because the HPCSA is not a membership-based organization, it's a regulator. A regulator established by an act of parliament, which is the Health Professions Act number 56 of 1974. What that simply tells you is that any entity that is established by an act of parliament, we call it a creature of statutes. And what that simply means is that that particular entity can only exercise those powers or perform those functions that it is empowered to exercise or perform by the statutes that establish it. And what that simply tells you is that the HPCSA can only perform those functions for which it is empowered to perform under the Health Professions Act. Anything outside the Health Professions Act, the HPCSA cannot do. So whatever we do, we are informed by our statutes. Now, the Act is very clear in terms of what council is established for. And you will forgive me, I will vala without even going through the slides, but I can guarantee you that I am talking the slides that I'm just going to go through. I prefer to talk. What I'm dealing with now is on this slide, which if you want to understand the HPCSA, understand that the HPCSA, Health Professions Council of South Africa, has got 12 professional boards under its ambit, and most of the functions of council are carried at the professional boards because it is really a council of professionals. And when Parliament established council, it was very clear what council need to do to set standards for education, training, and registration, and the practice of the health professions in the Republic. So every profession registered under the Act within the Republic of South Africa, council through the professional boards has been established to set the standards for their education, training, and registration. Now, just to understand what education means, it means that we are responsible for the qualifications. As much as you have got CHE, you have got the Department of Higher Education and the training institutions, the HPCSA set the standards. It determines the scope of the profession, which determines the curriculum, and recognize that particular qualification offered by a training institution. Of course, CHE is responsible for that, but if a qualification is not recognized by the HPCSA, and here specifically talking about a particular board, then we call it a qualification not prescribed for registration. So when you have that qualification, you are simply a holder of that qualification not prescribed for registration. Now, the recognition of the qualification by the HPCSA makes it a qualification prescribed for registration. That's why when you have that qualification, it becomes easy for you to register with the HPCSA. Now, when you talk about training, that is when now you start to talk about those professions that after they have acquired a particular qualification, then they go through a period of training. Most of them call them internship training. And also for some professions, you have got training which is postgraduate training, especially in medicine, where somebody become a registrar, they are going through postgraduate training to become specialists. Then after that, all these qualifications, when you have them, you have to come to the HPCSA to be registered. Now, something very critical that colleagues most of the times do not appreciate is that while the universities confers upon you a qualification or a degree, a university has no power to confer upon you a professional status. So the reason why you have got statutory councils like the HPCSA and all other statutory professional bodies is because we take a person who is a holder of a qualification and professionalize that person, meaning that it's the HPCSA that confers a professional status upon a holder of a qualification. What it simply means is that you may have passed your degree summa cum laude from a particular university, but that does not make you a professional.
Now, council or the professional boards also regulate the practice of our professions, and we ensure that we foster compliance with the set standards. That's why when it comes to education and training matters, we have got these evaluations that we do to ensure that the standards are kept. And we also ensure that practitioners remain competent through continuing professional development. That's why we have got the CPT programs, which I know in the near future, for your information, is going to be changed so that we can have a maintenance of licensure to practice. And what it simply means is that now, just like your driver's license, you will be given a license to practice for 5 years. And then after 5 years, you need to apply for renewal of your license. And there will be conditions that you will have to meet for you to be able to be considered if your license will continue. And then also, council is empowered to investigate complaints lodged against practitioners registered under the Act. Now, that is just basically the structure of council that is in relation to the ministry and also parliament. You will notice there, very critical, that council does not report to the Department of Health, but reports to the minister. That's why the minister is the one who appoints council and the professional boards. So as much as we do work and support the work of the department, but we, even in terms of the Act, we support the policy directives of the Minister of Health, because we are directly linked to the Minister of Health and the Parliament that have established us. And in terms of the constitution of council, colleagues, council is composed of 50% of council members are professionals. These are persons that you, most of the time, because now currently we have got members of the professional board serving in council. These are people that you contribute towards by nominating persons to serve in the boards, just like you have done. We should be appointing the new boards with effect from the 1st of July, because the term for the current boards end on the 30th of June. So 16 members of council are designated by the professional boards. And then you have got one person from the Department of Health, one person from the Department of Higher Education. Then you have got a person from military or from defense. Then you have got 3 persons from University South Africa. And most of the times, those people are usually health professionals as well. Then you have got 9 community representatives and also a person versed in law. Then you have got those 12 professional boards, which I'm going to take you through just now. Now, the representation in council is that all the professional boards have got one person designated to council, but there are 2 boards, which we call the big boards, which are the Emergency Care Board and the Medical and Dental Professions Board, which has got 3 people serving in council. Now, I'm not going to bother you with this slide. Now, I'm going to take you through a few numbers. Now, these numbers talk to the statistics that we have. I thought I had the current statistics here on my presentation. Mr. Kobe, I hope it's not your presentation. This one is mine. No. Is this your presentation or mine?
I think you ran the one that was on it. I think that's the one that you sent earlier. You have not updated this one, I think.
Okay.
So I think, yeah. No problem.
Let me this because I think it's better that I share with colleagues the most recent information that we have. Let me see if I can share the slide on my side, if that can be possible.
Yeah, right at the next to your microphone at the top, you will see that there is a 10 screen share on.
Yes.
You click that, and then I'll confirm as soon as we can see your screen.
Okay. Let me see if I can share. I hope I'm not sharing what is in front of us.
Yeah, then just run the slideshow. We can see your screen. Just run your slideshow.
On my slideshow on my presentation.
Yes. Yeah.
Okay, let me see.
There we go.
You can see it now.
Yeah, now we are looking at your screen.
Okay. I think before I go into this one, I'll come back to it and I can talk to it without looking at it. I think what is critical is this one. This is our report because we are dealing with offenses under the Health Professions Act. I just thought, let me share with you our report for the past financial year. Now, this information is from the 1st of April last year to the 31st of March this year. But I also just need to mention that there's data we have not included here. And those who are in the optometry board, which may be the majority of the people here, maybe, is that we have got 1,325 complaints against optometrists are not included into these statistics. So if you were to add this number, the 1,300 to this number, it means all in all, we dealt with 3,600 complaints in the past financial year. But with the information in front of us, is just to tell you in numbers, that is, those are the complaints excluding the ones for the special project. We had 2,338 complaints, of which 109, and this is very critical for us, and without bothering you with the numbers, I prefer to go to the percentage. So out of all those complaints that we received, you will notice that 4.6% of them were resolved at perusal and analysis. Now, this is very critical for us, and this talks to the initiative we made during our turnaround time, where we said health professionals should be the ones who investigate complaints against other health professionals, and that also includes the aspect of perusal and analysis. Now, these are complaints that were closed without proceeding to the next stage of registration. So 4.6% of our complaints, because we have got a health professional doing that perusal and analysis, was able to close 109, which convert into 4.6% of the complaints before they can get into the system. Now, those complaints which were investigated were 64%, whereas routine investigations, which are normal investigations, were sitting at 48.9%, while Section 41A investigations are sitting at 51%. Now, let me explain to you the difference between routine investigation and Section 41. In fact, it's not Section 41, but Section 41A investigation, which talks about the way certain investigations will be conducted. And this is where, colleagues, we do investigations where there is a complaint, but it does not specify the practitioner against whom the complainant is complaining. And at the same time, we also use Section 41A to access information that will be difficult for us to access. Sometimes we want information from you as a practitioner, and we realize that if we were to ask this information from you, you may hide the evidence or interfere with the evidence. And this is where, using the provisions of Section 41A, we go to the magistrate, obtain a search warrant to come and do a search and seizure at your practice to get the information that we need. And we use this especially for matters related to fraud, where we will have the information that is alleged that you have committed fraud. So we go to the magistrate, get the search warrant, come to your practice, and then get the information. Then what happens is that if there is no complaint lodged against you, the report that is generated by the investigator, if it reveals prima facie evidence of unprofessional conduct, that report is deemed to be a complaint to be served to you for the purpose of an inquiry in terms of Section 41 of the Act. So that is what Section 41A investigation talks to. Whereas routine investigations are those ones that we receive a complaint, then we request you for a letter of explanation normally, without having to go the route of Section 41A. Then 31.4% were referred for mediation by the Ombudsman, that is my office. Now, this slide is very interesting, and I'm happy to be presenting this to you after our regulations were amended this year in January. Majority of the complaints that we are receiving, we receive them through emails, and only 1.3% through post, and walk-in at 6.2%. Now, previously, before the amendment of the regulations in January, although we received 92.5% of our complaints through email, we would have to print them, those emails, because in terms of the regulation, an address did not refer to an email. It referred to a physical address or a postal address. So because of that, we were forced to convert what is electronic into paper so that we can serve you. But the amendment was done in January, where now the definition of address also includes an email. So now we can work electronically via wire, meaning that we can serve you a complaint electronically. Now, where do complaints come from? Majority of our complaints comes from the members of the public. And then that is at 73%, followed by yourself reporting each other at 8.1%. Then the medical schemes follow at 6.6%, followed by the Inspectorate Office, then the Ombudsman at 3.9%. Now, the Ombudsman is matters that cannot be mediated. Some, although they are referred for mediation, we realize that could be in error, or the matter is a failed mediation where the matter cannot be resolved, then it goes back into the system. Then the rest will follow. The other entities also include the Office of Health Standard Compliance, the Consumer Commissioner, because we do have a service level agreement with them, that because we self-regulate, if there's a complaint lodged against any of you as practitioners, the Consumer Commissioner will refer that complaint to us. Now, this is a very interesting slide, colleagues, and this talks to what kind of complaints are we dealing with. And this is where your offenses come from. So we have put together, we are tracing, and we started this process in April last year. So we have got this data for 12 months now. Now, it shows us that the most common complaint that we are dealing with, or nature of complaint we are dealing with, is that of negligence. And then the second nature of complaints is related to accounts. Now, you colleagues, sometimes, you don't even know how to deal with the issue of accounts. And this emanates from the fact that we think that when we issue our patients with statement of accounts, we are making them a favor. But in terms of Section 53, You have to do it even without the patient asking. So it's peremptory that you should issue or furnish your patient with a statement of account